Thanks, Jeremy. Good afternoon. I just want to get this on. Okay. So, yes, as you advertised on the email yesterday, I was going to also discuss the tuberculin skin test as part of my discussion, because it's also something I think can cause a little bit of confusion. But as with, I always find it is with TB, the more I read and the more I learn, the more questions I actually have. So I found this to be quite a big topic already. And so I won't be covering the TST in this discussion. So so I did title it Friend, Foe, or Just Feeble, and hopefully you'll see why I was wondering this during the talk. Okay, so you can't read anything about TB without a preamble, the first paragraph on anything about TB telling you exactly how high the burden of TB is and how severe a disease it is. So it's estimated, so why it matters to prevent TB is that it's estimated that about a quarter of the global population, around 2 billion people, is infected with Mycobacterium tuberculosis. It seems like at any point in time, that is how many people have been exposed to TB. There are, certainly for the past few years, estimated to be about 10 million new cases of disease each year. And obviously quite a lot of it is actually undiagnosed as well. And then 1.6 million people die from TB each year. And relevant especially to me and peds is 10% of those deaths are in children. It's also the 13th leading cause of death worldwide. And it's a second leading infectious cause of death after COVID-19. It's everywhere. It's in all age groups. So it's a very, I think we all know it's quite a relevant disease. Those who have a high risk of transmitting TB are people in prisons, nursing homes, homeless shelters, drug treatment facilities, and healthcare facilities. So wherever there's probably substandard living conditions and overcrowding, then that doesn't mean you're going to get TB, but you're certainly going to have a lot of transmission of TB. And there's a high risk of developing TB disease in particularly children under 5 years of age. And as you all know, in HIV positive individuals not on treatment, and other causes of immunocompromise. So there is a long list, but these are the two major groups of patients who are at risk of developing TB disease. And it's also strongly linked to poverty, which is most likely because there is generally then overcrowding, poor ventilation where people live, as well as malnutrition, and that all because obviously if we also exposed to TB and so many of us don't get TB, it's obviously is linked to certain living conditions which make people more susceptible. It's estimated that about 13 billion US dollars would be required annually to prevent globally to prevent, diagnose, and treat TB. And this is specifically with the aim of if we were to reach the end TB goals by 2030. Also, MDR TB is on the rise. Other issues are that the lifetime risk of TB disease after infection is around 5 to 10%. And the risk of TB, if a child is infected under 5 years of age, the risk is 20% or even higher. So, as you see, I'm going to talk about the BCG. So preventing TB, the history of the BCG vaccine. It seemed to start in France. So there's a lot of French names here. In 1865, Jean-Antoine Villemin noted that rabbits seemed to be able to become infected from humans. He later discovered they could also be infected from cows, and then also amongst each other, they could infect other rabbits. So the conclusion he drew was that TB is transmitted by an infectious organism. A little later, Robert Koch suggested that bovine and human TB were identical. But in 1901, he actually distinguished the difference between the two. So obviously they're quite similar, but there obviously also is a difference. And in view of the smallpox success, where cowpox was used to vaccinate against smallpox, because when smallpox was introduced as a means of vaccination, it caused severe illness, but cowpox actually induced protection against smallpox subsequently. So they thought that infection with bovine TB might actually protect against infection with human TB. So late in the 19th century, trials were using Mycobacterium bovis were conducted in Italy. Unfortunately, this had disastrous results because M. bovis turned out to be just as virulent as MTB initially. So here come the French, the Albert Calmette and Camille Guérin in 1908 subcultured virulent strains of TB bacillus using using different media. So they tried various different things and seemed to settle on a glycerin bile potato mixture, and apparently at some point were even just culturing them on slices of potato, and found that this produced much less virulent bacilli. And they repeated this subculturing over and over and over, and it produced enough attenuation of the bacteria to then produce the vaccine. So it was subcultured 239 times, and this took 13 years. Apparently, a lot of this was during the First World War, and it was very difficult to get ox bile, and potatoes were very expensive, but they persevered. And also because TB is such a slow-growing organism, this took a long time, but eventually they came up with the BCG strain that we now use pretty much today. But they did continue their research through World War I. They found initially when they tried this on animals that it caused no disease in animals. And in 1921, it was used for the first time on humans, starting with a baby born to a mom who had TB. It was just given orally. They tried it 3 doses, 2 days apart, and it was mixed with some milk given to the baby, and the outcome was very good. And then they gradually used it more and more, but it seems the acceptance was quite slow. They weren't doing any organized controlled trials. They just tested it out. And in the 1920s, the Pasteur Institute started mass production of BCG. Between 1924 and 1927, the two of them managed to vaccinate over 52,000 children. More than 6,000 were born to families with TB, and they reported that the BCG produced a drop in TB deaths from 25% to 1%. And they also documented a drop in childhood deaths in those who were vaccinated, not only from protection against TB. And slowly and steadily, other countries adopted vaccination. Unfortunately, a bit of a setback was the Lübeck disaster, which happened between 1929 and 1933, where 251 infants who were vaccinated in the first 10 days of life, of that group, 173 actually developed TB and 72 died. And they found later that the BCG had become contaminated with a virulent strain which had been stored in the same incubator. And there were also obviously legal consequences. In Sweden, a doctor there tried intradermal application because it had been oral up to then. And this was found to produce, because they'd already discovered and created the purified protein derivative, so PPD. So they found that this produced positivity with the tuberculin skin test. And that was at that point regarded as a marker of protection. So it was assumed that if they gave it intradermally, this would provide protection, possibly better than oral. But before this, others had actually discontinued intradermal vaccination because of increased local side effects. There was ongoing continued controversy about the efficacy and the optimal route of administration. But despite this, the BCG, because of the global burden of TB, it was promoted in 1948 by the WHO and UNICEF. So at some point, obviously, more controlled trials were actually carried out. There was a Dr. R.G. Ferguson, who is considered a pioneer in TB vaccination in North America. And he's been stated as possibly having carried out one of the first randomized controlled trials in Canada. Not perfectly randomized by modern scientific standards, but in some way it was randomized. And he carried these out between 1933 and 1945. I mean, it was a bit controversial, I guess, because they were giving it to not necessarily people volunteering to be studied, but and it wasn't proven to definitely not be dangerous and definitely be effective. But he felt that he knew that the First Nations people had a 10 times higher risk of death from TB, and they did warrant some intervention. So he tried this out on more than 600 First Nations newborns, and they were initially given the BCG orally with milk, and that was in 1933. And the next year, 1934, he decided to try it intradermally. And he was later recognized as, this was later recognized as being one of the most scientific trials of BCG yet made. And it was found to have about a 67% efficacy. Other trials, there were larger trials with more robust design, evaluating efficacy starting in the 1930s. In various countries and in various settings, but it was found that the efficacy varied considerably. The largest BCG vaccine trial included over 260,000 participants in India, and this started in 1968 and showed no evidence of protection against pulmonary TB compared with placebo in over 7 years of follow-up. But contrary to this, one of the earliest BCG vaccine trials with a robust design done in North American First Nations people by a different doctor between 1935 and 1938 showed long-term protective efficacy for pulmonary TB of 82% after 20 years and 52% after 60 years of follow-up. So these are obviously quite discrepant from one another. So why would there be such drastic variation in reported efficacy? So there's a number of reasons. The study design could be part of the reason they differed. The India study was criticized for methodological flaws. There's also, although it all derived from that original BCG strain, there are different substrains. So there might be a variation in the vaccine substrains used, causing these differences in efficacy. And also different media are sometimes used. But it's also thought very possibly to be due to exposure to environmental non-tuberculous mycobacteria. So these, as you know, are ubiquitous. And I put the picture of the map of the world here because one thing I read said that you get more and more non-tuberculous mycobacteria as you get closer to the equator. Other things tend to say that not necessarily more, but certainly different. So your NTMs differ depending on your latitude. And they are everywhere, and they produce what is called environmental sensitization. So we've all been exposed and we become sensitized to them, and they don't really cause much trouble in most people. And this exposure could actually alter efficacy in trials by one of, or even both possibly, of two proposed hypotheses, which are either masking or blocking. So the hypothesis of masking suggests that people have already been exposed to similar antigens. So when you're trying to measure the efficacy and any improvement in your in immunogenicity after giving a vaccine, you might not note a benefit because they already have been exposed to similar antigens. And the other hypothesis is that there's a blocking phenomenon, and that you have pre-existing immune responses which actually block your assimilation of the vaccine by the host. And they say they're not necessarily mutually exclusive, both could be going on at the same time. So these could very possibly lead to differences in efficacy in different studies and in different places. And then there's also other geographical factors and host factors. So coming to BCG being friend, and obviously we have to give BCG credit for a lot of things. It does give cross protection against other mycobacteria. So it produces a positive skin reaction to an intradermal. You can see a positive skin reaction if you give intradermal injection of heat-killed Mycobacterium leprae. So subsequent studies were done and showed that BCG actually had variable but a significant improvement in efficacy against leprosy. So that's a picture of the devastating effects of leprosy. It's also been found to be up to almost 50%, have 50% efficacy against Buruli ulcer caused by Mycobacterium ulcerans, which is also looks like quite a devastating disease. And it's also been shown to protect against non-tuberculous mycobacteria, which apparently are even, well, like I said, they can be present throughout the world. They're in the environment and can cause lymphadenitis in under sort of up to 5 years of age in young nursery school going kids. And they found that certainly in countries where they decided to stop giving everyone BCG because the incidence and prevalence had decreased, so they just gave selective BCG, and then they actually found that this rate of non-tuberculous mycobacterial lymphadenitis increased. So it was producing a protective effect against things other than just TB. And it also, the effects of the BCG seem to extend also beyond protecting against mycobacteria and seem to offer protection against certain viruses, bacteria, and parasites even. And this is thought to be, again, because of heterologous lymphocyte activation, somehow boosting the innate immunity, as well as enhanced cytokine production. So even if there's not necessarily cross-reactivity with similar antigens, because it doesn't create and induce a very typical antibody response, it does much more than that. It's actually protective against other diseases. And so this is called either heterologous, off-target, or non-specific effects of the BCG. And they noted this actually early on when they started testing out the BCG vaccine, that there was actually a 4-fold reduction in non-TB mortality in the first year of life, which actually was quite puzzling and interesting because they expected that they would just see a decrease, hopefully, in TB-related deaths, which usually only manifested after 1 year of age. But they were also seeing fewer babies dying under 1 year of age, which couldn't just be from an improvement in TB deaths. And this was noted in other countries, and it's been supported by several controlled trials. And then in a meta-analysis of 26 cohort studies of 68,000 individuals by Leonardo Martinez and colleagues, in the Lancet Global Health, it was found that BCG consistently and highly protective against death. They found more than 80% effectiveness up until 14 years of age in the 4 studies reporting mortality outcomes. And so, again, this protection conferred by the BCG seems to go beyond what is expected from just protecting against TB. And this is just a picture, well, it's sort of kind of all-encompassing to remind ourselves of the processes that are involved in immunogenicity with when you give the BCG, and also what happens when one is exposed to TB. So the initial step is that macrophages will phagocytose the bacilli, chomp them up and process them. And what they do then is present the antigens that they've processed, and they either expose them on the surface attached to an major histocompatibility complex molecule 1 or 2 on the surface, and then present them to your helper cells. And then they get presented to CD4 cells and CD8 positive cells. So in TB, but particularly with BCG, there's processing through the MHC2 pathway with preferential stimulation of CD4 positive T cells. Going into your immune response side, it's basically showing us this all happens mostly in lymph nodes and lymphatic tissue. And it's a process of making some antibodies, but the big thing is priming CD4 positive cells, creating memory, and priming CD8 positive cytotoxic T cells. And what happens then is they now make specific immunity against TB, but because of this cross-reactivity, these primed CD4 and CD8 cells will actually also recognize and be able to fight various other mycobacterial illnesses, like I mentioned. And off target, they can also decrease mortality, especially in low middle income countries, against the burden of disease, and can also affect other illnesses as well. But CD4 cells, the major way of killing TB is that CD4 cells produce cytokines, especially gamma interferon. That seems to be particularly crucial to killing TB, mycobacterial specific gamma interferon. And MHC1 restricted CD8 positive T cells are crucial in immunity to Mycobacterium tuberculosis, but unfortunately BCG only induces weak stimulation of CD8 positive T cells. So although it's causing quite an immune response in the CD4 cells, it's not enough of a response in the CD8 positive T cells, and that's quite important for vaccinations being successful. So, but still on the benefits, despite variably reported efficacy against pulmonary TB, BCG has consistently shown a high, up to over 70% protective efficacy against disseminated forms of TB, which includes TB meningitis and miliary TB. And that is obviously the TB that the children will get, the young kids will get, and that will kill people and cause obviously also long-standing morbidity. So, and recent studies also suggest that BCG can protect against TB infection as well as progression from infection to disease. Yeah, so why one might say, is it feeble? So the downsides of it, well, just not convincing enough that it's the best vaccination, is that infant BCG vaccination was 37% effective against all forms of tuberculosis in children younger than 5 years, and only 42% effective against pulmonary disease in children younger than 3 years, but did not offer protection to adolescents or adults after close exposure. Sorry about that. Okay, so that's not great protection. And the problem is that it only lasts about 10, if you do produce immunity, it only lasts up to 15 years. The other problem with, no, I'm sorry, please give me 2 minutes.
Okay, no problem. I'm just going to put the link to the CPD points in the chat in the meantime while we wait. So in a couple of seconds, you'll be able to click that into your details.
Sorry, I have tried to quiet my dogs down. Okay, so they can measure immunogenicity by measuring specific gamma interferon produced by CD4 positive cells, but there's a lack of correlation with BCG-induced immune protection. And so although that doesn't always correlate clinically to protection, and that's one of the problems because of the complex immune processes with TB and the BCG. The other problem is waning effectiveness. So there's little or even no protection against adult type cavitary disease, which is responsible for the major transmission of TB. So yeah, even though we're protecting kids, unfortunately later on there's still transmission. So, and the other thing they found is that they've tried to revaccinate, for example, in adolescents and adults, but it hasn't shown yet to increase protection, not with the current BCG. So just to brush up on the BCG vaccine that we're actually using currently, I'm sure everyone knows it's given intradermally. And I mean, it's supposed to be. And I think quite often, if anyone who's done a tuberculin skin test knows how difficult it is to actually get it intradermally. And a lot of the time it might end up being subcutaneous, which leads to more complications. So it has to be given intradermally. And when I was looking through pictures, I thought, why are some of these, actually most of the pictures are on the left arm. So those are different. The WHO actually says it should be on the right arm, but I think in many countries it's given on the left arm. I suppose this is really just out of interest. And as I understand it, it probably has something to do with where the smallpox vaccine used to be given. So in our country, certainly it's given in the right arm. The standard dose is 2 to 8 times 10 to the 5 colony forming units. We give 0.05 mils of the strain we use is the BCG Danish strain. There's been worldwide distribution of BCG since the 1920s. But obviously it's been subcultured in different conditions, which does result in genetic and metabolic variations. And the WHO decided to standardize production using a seed lot system, which I believe means they can culture it from reculture and subculture it from a specific lot to keep it more standardized. And they also introduced freeze-dried storage since the 1950s. I was just vaguely interested because sometimes students ask what we sometimes see these other scars, and we sometimes see people with a scar on their back or their shoulder, and I think that's a little bit confusing because there's also the HEAF test, which is a multi-pronged test, TST test, but the scars you might see on arms, and you're probably not going to see it much nowadays, certainly not in younger individuals, you may see a smallpox scar. So the smallpox vaccine was actually stopped in 1982 in South Africa, and it tends to produce a depressed and irregular lesion or scar versus the small bump, which we're actually used to seeing from our BCG. And I think basically the smallpox was traditionally given in the left arm, and that's why we use the BCG on the right arm. It's just for standard, it's just for so that everyone does the same thing. And that does also often raise questions when we have to do tuberculin skin tests, and we do that on the left forearm. It apparently has absolutely nothing to do with the fact that it's opposite the arm where you got the BCG. The reactivity has nothing to do with each other. It's just, again, for standardization. So currently there's 10 different, well, I don't think we're going to get any more of that BCG. There's 10 different substrains, and there's only a limited number of manufacturers worldwide. UNICEF procures the BCG on behalf of 70 resource-limited countries and distributes them. But there have been global shortages, as I'm sure everyone knows. They talk about the global shortage in 2015, 2016, but it would appear that the shortage is still ongoing and expected to continue until 2024, 2025. So the problem is that the countries with a higher TB incidence obviously require higher BCG coverage, and they are usually the ones who are most affected by shortages. And you can imagine that even a small shortage can lead to thousands of TB deaths. This is a BCG vaccine strain map, just showing the different strains that are used in different countries in the world. So the different routes that are used, because I must be honest, when I heard about IV, and especially during COVID, when we heard that they were considering using that BCG might offer protection against COVID, I thought, how could you give it IV? But certainly different routes have been considered and tested. So the oral route was initially used, and apparently Brazil used this until 1976. And the rationale is that it's an inhaled pathogen, so it would activate mucosal lymphoid tissue, as would taking it intraorally. So oral exposure produces higher concentrations of mycobacteria-specific secretory IgA. But the question really is, and I don't think there's an answer, does this translate into enhanced protection? Especially when we know that the immunoglobulins aren't, antibodies aren't that essential, well, that pivotal in TB immunity. Then other methods, intravenous and inhaled, aerosolized. This has actually both have been proven to be superior in animal studies, but they're not practical for mass immunization, and they would require 10 to 100-fold higher doses. So not in use at the moment. And as for the intradermal route, it produces more pronounced lymphoproliferation and higher mycobacteria-specific gamma interferon release by T cells. The adverse effects, it's more indolent than you might say many of our other vaccinations, which might cause some irritability in kids and redness and fever. It's more indolent, but happens eventually, usually after about 3 to 4 weeks. And it usually creates, as one would expect, a granulomatous reaction at the site of inoculation. So that's normal. It occurs in 1 to 10%, but it's expected that it's actually underreported. And it usually happens within the first 6 months. But some events can happen up to 12 months and even years later. But then I would imagine it's quite difficult to tell now if this is BCG or actually TB. Unless you can prove it. But they think the adverse events or the likelihood of getting a reaction might depend on the strain, the dose. So sometimes accidentally someone gives double the dose or something, and it might just be more likely it'll cause a bigger little lesion, maybe even an abscess there. And the technique is very important. So it isn't supposed to be subcutaneous. And obviously underlying immunodeficiency is a definite risk factor for complications. They've also found that the younger the patient, the more likely they are to have an adverse reaction. But when they've looked at delaying till the baby might be 10 or 14 weeks, the problem is that we're talking high-risk settings, so it's probably more dangerous to wait. And I think especially in our setting, it's difficult to always bring the patients back again. So we still give it at birth. So in terms of FO, and this is the times when BCG causes problems. Like I said, a bit of a lymphadenitis is often expected. So often when we examine a 1-2 month old infant, we can usually feel a little bit of a lymph node on the right side. And it's usually ipsilateral, can be axillary, even cervical, supraclavicular, or even nuchal. So it doesn't necessarily follow a chain. And I have seen it in a child, supraclavicular, which obviously makes people worry. They think that's a bit too far from the site of injection. But these have been described. They can also produce an abscess, ulceration, and sometimes if it by any chance is given in the leg, it can, for example, it can produce a persistent injection site reaction with some swelling. And usually the diagnosis is clinical. If the timing is right, that's where the BCG was injected. It's usually assumed that's from the BCG. But it should produce a non-suppurative lymphadenitis. So that's normal and an expected part of the course. And it should resolve in a few weeks to months. And I think one of the major issues, and this has probably happened to quite a few people seeing children, that people they go a bit too far with this. So I've seen a child, perfectly well child, who just developed a lymph node, actually a little bit further than the axilla. It was supraclavicular. And then they were treated for TB. The mom was told she needs to give the child TB treatment, and she questioned that, and it became quite a thing. So obviously she did not. The child was growing. There were no other features suggestive, and waiting and watching. But sometimes you might have a parent who definitely wants to treat this, other times not at all. So as often I find with TB, follow-up is pretty important. So that's a picture of a little bit further away, a lymph node, and then when they ulcerate and start to drain a bit. And then systemic reactions are rare, but varies between 1 and 17%. And again, probably underreported or not always necessarily diagnosed correctly. But a regional disease is osteitis in the same arm, obviously, and even osteomyelitis, which has a good prognosis, but that would be with treatment. I don't think they're going to get away without treating with the correct BCG TB treatment. And then disseminated BCG disease or BCGosis, which can even be life-threatening with quite a potentially high mortality rate, up to 70%. And that's seen mostly in primary immunodeficiency, particularly subacute combined immunodeficiency, but that's pretty rare. And so our fear has always been in patients with HIV and giving HIV-exposed infants the BCG at birth. So at some point, I think it was around the early 2000s, it was debated, the new policy almost was that we should wait for the 6-week PCR and then only give the BCG if the baby was negative. But I think there were too many delays and possibly missed BCGs, and it turns out actually it's not particularly dangerous in just an HIV exposed infant. So it would just be babies who are born looking like they have symptomatic HIV infection, you know, IUGR baby, small for gestational age with hepatosplenomegaly, lymph nodes, a whole lot, that you would be particularly concerned. Otherwise, the practice really is now to obviously good ART, but as we would give the BCG. It's clinically, it looks similar to disseminated TB with lymphadenopathy, hepatosplenomegaly, failure to thrive, and it can even present with this nondescript rash. Yeah, and I feel we might have actually seen this recently in one of our patients. Unfortunately, there are no consensus guidelines for treatment of this or necessarily for, the diagnosis should be by taking samples from the relevant places. But I think it should be important to note that there's probably not much point in sending off an FNA from the node near the BCG, because you expect that to be BCG. But if you can find it elsewhere or on a TB backtech, and they can identify it as M. bovis, then that's helpful, because you need to know. But quite often, I think we end up, well, not that we see that often, but treating as TB and covering with 4 drugs, because the BCG is resistant to pyrazinamide. And then I haven't included this, which I should have. We do sometimes, and I think we saw this, we used to see this a lot again around 2008, when we were starting to treat patients a little later. We weren't starting treatment from birth and diagnosing as many babies early. So they would start ART later and then develop BCG iris, which looked the same, but actually they did pretty well. It wasn't as devastating as when you have disseminated BCG disease in an immunocompromised patient. So the management of local disease, again, there's no consensus. People seem to do different things. Probably they overreact more than underreact. If it's not suppurative, doesn't feel fluctuant, then it should be left. Parents reassured. If it's suppurative, you can perform needle aspiration. If it's causing a mass effect and it's painful for the child, they can't put their arm down normally, and sometimes it's very makes the mother very anxious. There were always sort of this guide that you should not just stick a needle in, you should go under the node so that you don't create a tract, a fistula. And they've also talked about injection of INH, installation of INH in the node, but no actual controlled trials have been done on it, so it does need further investigation into the use of INH. But they don't advise removal of the node. One doesn't really want to remove lymph nodes and cause lymphedema later, unless it's necessary. And then for regional disseminated disease, to give TB treatment, bearing in mind that there's pyrazinamide resistance in BCG. And as I mentioned, prevention, but to delay BCG in a symptomatic HIV infected infant, or presumed symptomatic HIV infected infant. But otherwise, both BCG is still advised in well HIV exposed infants. So new BCG vaccines in the pipeline. The question really is, why has an imperfect vaccine for such a prevalent, in such a highly infectious disease, which has such substantial mortality and morbidity, not been replaced or improved upon? And it's been around for so long. Part of it, I do also think, was that it was sort of slow to start. There were 2 world wars in the meantime as well. And a lot of the countries where they wanted to start using it, they were carrying out pretty long studies and trials looking at the efficacy. And one might say, if we knew earlier that this wasn't going to be great, we should have started sooner to develop something better. But it's also mostly because TB vaccine development isn't easy. Because of this complex immunology, not just a simple case of producing an antibody. There's T cells involved and interferon and things like that. And also this lack of a correlate of protection that you can, studies being done, you can see the gamma interferon rising, measure that, and you can look for specific CD4 and CD8 cells, but that doesn't necessarily mean that that's an effective vaccine. And there's a long latency period. So I guess while you're following these patients up, the period to follow them up for to make sure they don't develop TB, you know, if they don't develop it in 5 years, that doesn't mean that they aren't going to a little later. So that's your monitoring your effectiveness of your vaccine. It takes time. And then TB research has also been chronically underfunded. I also read somewhere that BCG research dropped off when TB became all but eliminated in the West due to improved hygiene, social circumstances, nutrition, things like that, as well as vaccinations. So the places where there'd be a lot of money and funding for vaccine development and improvement, they might have, you could say, lost a little bit of interest. But certainly we need a TB vaccine, an effective TB vaccine now more than ever. It's still extremely prevalent in many developing countries and impoverished areas, even in developed countries. It's not gone from anywhere. Obviously, there's also been setbacks due to the COVID-19 pandemic. So whatever they'd gained in terms of decreased TB infections, they shot up again because of broken down systems and inadequate prevention and early treatment during the pandemic. Obviously, HIV, although many people on ART, it's still a major problem, HIV and TB together. And there's also increasing multi-drug resistance. So the three main strategies are either looking at prevention of infection, so looking at giving it at birth, so a replacement for what we have now, given at birth or to young children who've had no previous exposure. Then looking at prevention of disease, so that would be targeting infected individuals, which is, I think, the way they do it in some countries where it's not that prevalent, but they look for either patients with, so I think this happens often with a lot of immigration into certain countries. Then they're going to test those individuals, and if it looks like they've been exposed, if they have a positive TST, then they know they have to get, they might want to give a BCG, but they would probably most likely just treat them at that point with TPT. But you would want to target infected individuals and prevent progression to TB disease. And then there's also looking at prevention of recurrence. So after completion of TB treatment, to prevent reinfection or reactivation. Another thing they're looking at is therapeutic immunization, which would be good if it could shorten or adapt the treatment regimens with adjuvant vaccines. So, for example, in drug-resistant TB, when we're running out of options of drugs and there's so many drugs that have to be used, you might be able to add on a vaccine. So currently, there are more than 20 different vaccines in preclinical and clinical studies. The three things they're looking at are live attenuated vaccines, inactivated whole cell, and subunit vaccines, where there's either an adjuvant or a viral vector required for sufficient immune stimulation. They always require preclinical testing in animal models, and then phase 1 trials in small groups of healthy adults to document safety and tolerability. Then they go on to phase 2 trials with larger numbers who have specific clinical and larger clinical characteristics. And then phase 3 trials with large numbers and in multiple geographical locations. So obviously, I just learned a little bit more about this now, but many of you probably know that there are exciting trials happening right here in South Africa and at our hospital, Rahima Musa, as well as Barra. One of those is the VPM1002 vaccine, which is a live attenuated vaccine. And the aim of this, they've added listeriolysin from Listeria monocytogenes, which assists the organism to escape the phagocytes. And they've also inactivated the urease C gene. This gives a more acidic pH, which optimizes this listeriolysin activity. And the idea of this vaccine is it's one up on the BCG, is that it should direct mycobacterial antigens to that MHC1 pathway, which should improve the CD8 positive cytotoxic T cells, which our BCG wasn't doing adequately. So it should mimic immune induction of actual MTB quite effectively. They're looking at protective efficacy and immunogenicity by monitoring levels of gamma interferon after antigen restimulation using an ELISA technique, the quantiferon gold. And they also are measuring cytokine expression on CD4 and CD8 cells after antigen stimulation, and they're also looking at antibody production. It's given as a single dose, so patients who enroll don't get the normal BCG, and then they must get a single dose of this within 14 days of birth. They've already done 4 trials in this study. It started off with healthy male adult volunteers in Germany, and it was proven to be immunogenic and safe. And then they looked at healthy male and female adults here in South Africa with prior BCG exposure. In Cape Town, they did another study actually on newborn infants who were randomized to either receive the study vaccine or the BCG. They initially were looking at HIV unexposed BCG naive patients, babies. They found it was immunogenic and has a lower rate of abscess formation. And they've also done an HIV study looking at HIV exposed and unexposed newborn infants. It's been shown to definitely be non-inferior in terms of safety and tolerability, and it is immunogenic. And then another study ongoing also at Rahima Musa and Barra is the MTB VAC, which is also a live attenuated vaccine. Both of these are phase 3 trials. And this is attenuated. It's had 2 genes deleted to reduce the virulence. And it's also, there is an arm of the trial that's looking at efficacy in bladder cancer. And that is all. Thank you.
Cool. Thank you so much. It's a really nice overview. And again, you've done really well. Lots of people have commented about how much they've learned. So that's fantastic. If you do have questions, please just put them in the chat. And then I'm just going to post the link again for CPD points for anyone who missed the first one. Excuse me. Okay, I'm going to turn the video off. So a couple of questions to get you started, Judy. So one of the issues you raised was the sort of intradermal, nature of the injections that we give. Characteristic that should lead to a bleb under the skin to make sure that you intradermally, you're not doing it subcutaneously. I understand from people who've been training, the primary healthcare clinics to do this, that they worry that the level of intradermal injection as opposed to subcutaneous is quite low. In other words, people are not doing the administration perfectly correctly. Do you know if any research suggests that, how prevalent a problem that is, or is this likely to be a big issue? Because in South Africa, was it just sort of anecdotal at the moment?
I'm assuming when you say not enough is given that because it offers quite a bit of resistance, it sort of squirts out and you don't get it into the skin. But I didn't come across anything that suggested that we would be concerned that it's not getting in. And I'm not sure if now I'm seeing that it said 2 to 8 times 10 to the 5. So maybe they err on the larger side, the larger amount, just in case, because it's quite a variety, quite a range of the amount needed. So maybe that's taking into account that some might be wasted, but I'm not sure if they've actually looked at how many aren't getting enough actually. Yeah,
interesting. And then I was curious about the regimen you would choose for BCG, disseminated BCG in children. Like you said, the PZA obviously is not an option for bovis. For an adult medicine where we use ethambutol all the time, we would just keep it easy. We just give them Rifafor, knowing that the PZA won't work, and extend it to 9 months. In other words, they're effectively on 3 drugs. So I don't know, what do you do in PEDS? What would you recommend? Because I know you said you'd suggest 4 drugs.
Yeah, like I say, I don't recall the last time I actually treated this. So anyone who has, I'd be interested to know. But as far as I know, we are giving the ethambutol these days anyway. We used to be worried about the optic nerve toxicity, but we are still using it in younger kids. So we would probably, I think, end up giving 4 drugs, especially because they are particularly sick infants, usually with this that we've chosen to treat. So, and we often aren't sure if it's BCG or TB. So at least this way we'd be covering our bases.
Got it. So you'd something like rifampicin, isoniazid, ethambutol,
yes.
And what for the 4th?
I think we'd still give the pyrazinamide because we
in case it's TB.
Yeah.
Okay.
Yeah.
Got it. And as seen in the chat things, we give a fluoroquinolone. I guess if you know it's BCG, I guess then that would be the 4th drug to give. Yeah. Okay.
Yeah,
interesting. Yeah, but I take your point. There's a lot of them might be TB.
I saw something as well about erythromycin, but I don't know why anyone would be adding that. But I did see, yeah, the quinolones
Okay.
being added.
All right. Just looking through, and then there's a question from Lauren saying, is there a sort of catch-up vaccination threshold for BCG? So, if they miss the dose at, say, birth, obviously you can catch it up, but I mean, is there a point at which it's pointless?
Yeah, I don't think, I've always wondered this, and I've looked, I think when there's such a high prevalence, it's certainly not contraindicated, assuming you're not immunocompromised. But so I don't think I would ever say it's contraindicated. You still can, and I probably would. But
Yeah.
I know not everyone feels that way, but I think it's still going to have a revaccinating later isn't useful from what I saw, but certainly I don't think there's an upper age limit where I'd say, no, don't bother. I still would give it.
Yeah. I mean, I guess it, as you said, depends on whether you're likely to be exposed in the meantime. Obviously if you've been exposed to TB, then it's not much benefit then. I know overseas they say a year. Julie's
Yes.
written in the South African guidelines for 12
months.
But I take your point. It's it may be futile, or at least likely to be futile after that point, but it's unlikely to be harmful.
Not contraindicated, because we've seen once in a while a patient developing TB meningitis, HIV negative, older patient, maybe 12 years old or something, and maybe because they missed the BCG. Well, they had missed the BCG, and it's just, I don't know if it's worth the risk, because it's a devastating disease.
Sure. Yeah. Okay. I think that's it from the questions and that, but that's really, really interesting. And thank you. We've all learned a lot. And it's really helpful to know. I mean, so many people get it in this country. And as you said, it's quite interesting. It does have these sort of pleiotropic effects on other diseases in terms of boosting immunity, in terms of clinically relevant protection. I mean, remember when COVID started, people were investigating whether the BCG vaccination was protective. It turns out not. But at the time, I thought it was just a crazy idea. And in fact, it's not a crazy idea, given, as you say, some of the other evidence that it does prevent a wider range of diseases than just mycobacterial infections. It didn't work for COVID, but it's not crazy to think it might have.
Bladder cancer, it seems to definitely assist with that. So
yes, yeah. And we're still in adult medicine center using it as one of the therapies.
And they seem particularly hard hit by the shortages, the global shortages. If you look at that, then the bladder cancer, that seemed to be the major place where they were missing it and wondering when it was coming back.
Yeah. Okay, great. Thank you very, very